Okay, as we're coming up to 12:05, we want to make sure we stick to time today. I'm going to hand over to Lauren, who's going to start the presentation on mouth care and speech and language therapy. Thank you very much, Lauren.
Thanks, Kath. So my name's Lauren. I'm a speech and language therapist who works at the Great Western Hospital in Swindon. And today I'm going to talk about a quality improvement audit that we did as part of the acute inpatient team where I work. Just trying to move to the next slide. But might need Helen to move it for me. Thanks, Helen. So just to give an overview in terms of why we've been involved with mouth care for our patients, poor oral hygiene can have an impact on our patients in lots of different ways. Namely with communication, it can reduce someone's ability to articulate properly. It can cause pain when people are talking if they've got really sore ulcers or a very dry mouth. It can cause a lot of feelings of embarrassment as well, you know, if someone's suffering from bad breath or, you know, their teeth, their mouth generally doesn't look very nice. It can make them less likely to speak to others. Can sometimes have an impact on volume of voice as well, especially if people are dehydrated or they've been ill by mouth. And it can therefore make the voice also quite husky and lower in pitch. So it can have a big impact on communication. Next slide, please. But also swallowing. We also, when we're assessing patients on the acute wards for dysphagia, we're often looking inside people's mouths, unsurprisingly. And what we sometimes come across with poor oral hygiene is patients will have very dry or very sticky secretions that might impact on how well their tongue is able to move inside their mouth. And, you know, food or debris getting stuck can cause problems and also is a great place for bacteria to thrive. It can, you know, if someone has poor oral hygiene, it can often mean that our patients may not want to eat and drink as much, so you get a reduced appetite, which obviously has knock-on effects. And it can be painful to swallow, especially if someone's developed something like oral thrush, for example. It's going to make them less likely to want to eat and drink. Next slide, please. So there's been lots of evidence, especially over recent years, about the reason why we need to maintain good oral hygiene, especially for patients with known swallowing difficulties. Obviously, it can affect someone's quality of life quite significantly if left untreated. And we know from the research that aspiration of food and drink alone doesn't always contribute to someone developing pneumonia. It's often a combination of that bacteria inside the mouth as well that's being aspirated, you know, even just with patient secretions. So it's really important to get on top of this. And as speech and language therapists, we're having an increasing kind of role, I suppose, in, you know, supporting nursing staff to manage this and deal with this on the wards for those patients. Next slide. We're often seeing that people who are less likely to be able to complete their own oral hygiene are at an increased risk of mortality and developing chest infections, especially patients who, you know, may have upper limb weakness or, you know, simply through delirium or cognitive changes need that additional prompt and that support to complete good oral hygiene when they are with us as an inpatient. Next slide, please. So what all started, well, kick this off is in our hospital, we've also been doing a lot more free water promotion as a protocol with patients. So allowing patients to have free water, sips of fluid in between meals, even if they are showing overt signs of aspiration. And we're very aware that in order to make this work and make it as safe as possible, a lot of evidence says that you need to have good, rigorous oral hygiene in place if you want to implement something like free water protocols. So as a department, we've been doing a lot of research on this as well. Next slide, please. So last year, 2019, we saw that there was an increased amount of time that our inpatient therapists were delivering mouth care prior to doing a swallow assessment. And this was kind of increasing significantly. We were seeing over a few months, and we didn't really know why, and felt that something needed to be actioned. It came at quite a timely point in that we also had the Mouth Care Matters project up and running in the hospital. So there was some increased awareness amongst nursing staff about the importance of mouth care, but we were still being involved quite a bit. So we decided to do an audit. And what we did was we had a ward that was being used as a pilot ward for the Mouth Care Matters project, and that was our stroke unit and ICU. So we had those two wards, and what we wanted to do was compare and contrast those to wards that hadn't received any training. So look at the wards that didn't have any nursing training, but also didn't have any additional equipment to manage oral hygiene. So we were looking at the time, and we also wanted to look at the degree of mouth care that needed to be given. We used a mouth care assessment tool that I'll show you in a second, and also, where possible, gain patient perceptions of what sort of mouth care they had received in hospital. So we started the audit in January 2019, and sorry, we completed the audit in January 2020, that's a mistake, sorry. And we, unfortunately, in the first audit, we discovered that some of the pilot wards didn't have all of the equipment that they needed to do adequate mouth care. So we have since repeated the audit, which is just finished. So I'll talk about that in a bit more depth. Next slide, please. So I've gone through a little bit of this already. Essentially, what we did is we included every patient that was going to be seen for a dysphagia assessment within this audit, whether they required mouth care or not. So for every patient, whether on the trained wards or untrained wards, we were capturing within the data and then assessing their mouth care using the mouth care assessment tool, which gave them a plan A or a plan B outcome. I'll show you in a second. Logging that result, and then also the time that was given by speech and language therapy to provide mouth care, whether that was 0 minutes or 35 minutes. And so we did that until we had 30 patients from each. So that gave us a total of 60 in total. And we did that both times for both audits. Next slide, please. So this is just an example of the mouth care assessment tool that we were using. You can see it's broken down into various different areas. So assessing tongue, lips, saliva, whether the patient was nil by mouth, whether they required oxygen. And this is a tool that the nurses are also now using for every patient that's admitted to hospital. So there's been a lot more emphasis on mouth care, which is great. We also, in terms of equipment, we've been lucky to have the Striker mouth care kits funded in our hospital. They're the green sponges you can see there with the suction port. So they're great for delivering mouth care and come with chlorhexidine within the packs, which is really great for tackling bacteria, as well as things like the mouthy sticks and obviously a good old toothbrush and toothpaste. Where possible, we obviously would like to use those in the first instance. Okay, next slide, please. So you can see the results from the initial audit. Unfortunately, the post-training wards do score quite highly in terms of minutes spent delivering mouth care from speech therapy. So you can see we've got a total of 157 minutes the first time round, and 100 minutes for the untrained wards, so to speak. However, you can see that for the untrained wards, we did have slightly more contacts for 5 minutes. So, 11 patients on that caseload required 5 minutes worth of mouth care compared to 6 on the other wards. And then you can see there are some quite high numbers on the post-training, but again, patients are usually less able to do the mouth care themselves on, say, the stroke unit in an ICU, so that may account for some of that data there. Next slide, please. So we completed we started the re-audit in June, and just finished it now, and this re-audit included the Striker mouth care kits, which we were lacking from the first time round. And this has resulted in quite a stark contrast, actually. So you can see for the wards that are still without training and without the equipment, speech and language therapy spent 141 minutes delivering mouth care across those 30 patients that were captured. 19 out of the 30 actually required mouth care. The rest we didn't need to intervene. So it puts an average of 7 minutes of mouth care given for those 19 patients that needed it. And in terms of overall kind of mouth care assessment, you can see on plan B, we had 25 of those 30 requiring kind of an enhanced level of mouth care, or we felt that they should be receiving an enhanced level of mouth care. For the post-training wards, so they received direct training and also had the equipment. You can see that's significantly reduced. So speech and language therapy only delivered 85 minutes of mouth care for those 30 patients. And out of all of those, it was only 9 that required our input directly, 10 of which achieved a plan A for mouth care. So there's a significant difference. I think I worked out it was about a 40% reduction in time. So, you know, significant improvements, and the patients were often a lot happier as well, having received good levels of mouth care regularly. Next slide, please. So we'll just slip through these. I know it's lunchtime, but this is just some examples of mouth care that I've seen on the wards. And obviously, you know, we shouldn't really be having to deal with mouth care such as this, but the next few slides show kind of what can be achieved with mouth care. This last gentleman, he had mouth care after being seen by speech and language therapy. He had mouth care for over a period of a week, and if we show the last photo, you can see the end result is a beautiful, healthy, pink, clear mouth. So it just goes to show what can be done when, you know, awareness is given. So we've created some guidelines for mouth care to put above patients' beds. We've also been instrumental in doing some more training for nursing. And we've also created an oral hygiene and dysphagia leaflet that we've now been able to disseminate within the trust, which is on the next slide. So whistle-stop tour, but I think it's, you know, it's just highlighted how important mouth care is in the inpatient setting. I know that RCSLT are going to bring out some guidelines, hopefully end of this year or next, about our role within this topic. If anyone's got any questions, I'd be happy to answer. Thank you for listening.
Fantastic, thank you, Lauren. That was really interesting. We've been talking about mouth care for such a long time in the profession in terms of dysphagia outcomes, and I think it's slightly frustrating that we still haven't got necessarily a consistent approach to it, but I think audits and sharing projects like this are a really important way to start to really promote it in terms of it being part and parcel of, if it's not our role, it's certainly part of what we're trying to achieve as an endpoint, isn't it, in terms of healthy mouths and people who are able to eat and drink safely. And you can't really sort of disentangle the two, can you? So I think a more active role for speech and language therapy within mouth care is really important.
Definitely. And so Sally makes a good point.
Yeah.
Yeah, Sally makes a good point as well about, you know, it's not just about raising it as an issue, but also having access to the equipment. So, you know, our hospital as well, we were recently, you know, quite regularly using pink mouth care sponges. You know, I'd see them as the only sort of mouth care that patients were being provided. These have now been disused or, you know, not encouraged to be included in stock on wards, and now wards are really being pushed to use toothbrushes and toothpaste, which is, you know, it shouldn't have to have been a mind shift, but it has been, so it's good.
And can you tell us a bit about the Sky? Oh, someone's asking a question here. So yeah, someone's done an NIHR funded project looking at mouth care after stroke. Craig Smith, which was a useful reference. Thank you, Karen. And Helen's asked what your experience of doing an audit was.
So I've done quite a few audits in the past, but this audit, you know, never underestimate how long it's going to take to initially capture the data, then analyse the results. You always think it's going to take a lot less time than you think it would, but you know, I think if you've got a team on board, you know, I didn't just capture all the data myself. It was, you know, all of the inpatient team were contributing to it, and then I was kind of organising the analysis and things. So if you've got a supportive team, I find them quite fun and obviously quite interesting. You know, you want to improve patient care at the end of the day, so I think we should all be involved in them.
Yeah, absolutely. And do you have an audit department who were able to support you with this? Or yeah.
Yes. So they've helped me to create some lovely graphs and things with the data. So really appreciated there, and hopefully we'll push it forward as the project kind of evolves, and yeah, hopefully have a little bit of research at some point as well.
Fantastic. So there's a question about the use of non-foaming toothpaste.
Yes. So toothpaste that contain SLS or sodium lauryl sulfate, that foaming agent, is known to kind of dry out mouths. So especially, it's just like you get in your shampoo as well. So any sort of foaming agent will dry out oral mucosa. So especially for patients with dysphagia, or if they've got, you know, radiation effects, non-foaming toothpaste is a really good alternative, and it's much more gentle for the mouth.
Thank you. And there's another question here around getting the nurses to take ownership of mouth care, maybe some barriers to that. In the experience of Christine, what did you find in terms of the receptiveness of people receiving training?
Yeah, buy-in is, you know, you really need the buy-in from the nursing staff. Unfortunately for us, the Mouth Care Matters project here was primarily nurse-led. So, you know, we kind of already had that buy-in. But, you know, I think if nurses are provided with the time and the equipment and the opportunities for training, and kind of shown, you know, just better ways to do things, and, you know, given the research, they're often very receptive. You know, often it's a matter of time and or another form to fill in, but you know, training HCAs, asking them to get family involved, you know, it doesn't have to just fall to them. If they feel supported as a team, I found quite positive responses to mouth care.
Good, fantastic. Just quick final question. It's great that you've got evidence to give to your trust about training and awareness raising alone won't work necessarily without the other resources. Do you think the audit will help support continued funding of things like the Skylar packs you were referring to?
Yes, definitely. So especially that re-audit that we've just completed, it's a stark contrast really, and you know, everyone in the speech language therapy team has noticed the difference. So yes, I think there are already plans afoot to roll those Striker products out across the whole hospital, which is fantastic. And in terms of funding, that was from the wards.
Yeah.
So each ward individually, not just the SLT department.
Oh, that's great. That's another demonstration of buy-in, isn't it?
Yes.
Be prepared to put money into a resource. Thank you so much, Lauren. We can probably continue to chat about this because it is such an interesting topic, and there are a couple of extra questions. Perhaps you could respond to them in the chat box now you've got a moment.
Yeah, sure.
We move on to Alison's talk. So brilliant talk, Lauren. Thank you very much. If you do re-audit in future, I'm sure we'll be really keen to hear the results of that. And good luck. Brilliant. Okay, so our next speaker is Alison Drewett. Let me get her slides up.
Thank you.
Hi, Alison.
Hi,
lovely.
hello.
Thank you very much. I'll leave you introduce yourself and your presentation for today.
Thank you. So I'll just try and see if I can move through. So it's telling me that I've got remote control. Is that Kath? Okay, lovely.
Sorry, I was muted. Is it working all right, Alison?
It's not working for me. No, it looks as if you're going to have to.
Okay. Oh, something's happening.
Ah,
Could we perhaps go back to the start?
has Helen got control? Yes. Can we go back to the start?
Like it. If you just ask Helen to move the slides forward, that's probably
okay. Yeah. So sorry about that initial beginning. My name's Alison Drewett, and I'm doing a NIHR funded piece of research looking at autistic adult communication in inpatient settings in mental health. Yeah, can I have the next slide, please? Okay, so my standpoint in the research is very much as a clinical academic, and that's really very important in the research, because the standpoint means that I use my skills as a clinician and as a speech and language therapist in the research itself. So it's about me being an active participant in the research, and bringing those skills and that clinical experience into the research. And this is very much about what is being talked about in relation to ensuring that knowledge production, the production of knowledge, gets implemented and has a practice kind of orientation. So I'm currently working as a part-time senior lecturer in speech and language therapy at De Montfort University, but I'm also doing this part-time funded research for the NIHR. Next slide, please. I'm only midway through the fieldwork, because unfortunately the fieldwork stopped due to COVID-19. So for the last 7 months, I've not been able to collect any data. The research project is framed within a video reflexive ethnography approach, and I will talk about why I think that's a really lovely approach for speech and language therapists to be adopting in their research studies, and indeed has become quite internationally kind of used by lots of healthcare professionals, because it's a way of looking at practice as it happens, as it really happens, not as people imagine it happens. The study uses two main methods, which includes video and audio recordings of ward round meetings. So these are ward round meetings in mental health hospitals as they naturally occur, and then 18 reflexive interviews where I very much collaborate with the patients and the staff to engage in talk around how to improve communication in ward rounds, using the videos as a kind of a centerpiece, if you like. Next one, please. So my questions are about how does care happen? What is involved in care work for autistic individuals in mental health hospitals? The reason for focusing on that population group is that increasingly we're aware now through exponential research that if you are autistic, you are at a very high risk of developing or having mental health issues alongside that autism. The research looks at the idea of person-centeredness and what that actually means in real life practice, because it's very much a policy rhetoric that we all aspire to, but actually what does it mean in practice? So that's been looked at in relation to the interview data and the video data. And the interview data is also used then to ask people's perceptions. You know, what do people say about their experiences? Very different to what goes on, but what do people say about their experiences? Next slide, please. So it's a video recording of a naturally occurring event, which is basically the ethnography part of it. And it's about practitioners identifying improvements via these reflective discussions. And here I think you'll probably start to understand my earlier point about that my standpoint as a clinician is very much a part of that. It's not a variable that's controlled out of it because of subjective bias. It's very much in the room. So the patient standpoint as well sets the bar for the staff reflection. So it's very person-centered in that way. The patient tells me what they think about what happened in the video and what happened in the actual ward round. And that's used to start a discussion with staff. Next slide, please. So video reflexive ethnography is a methodology. That means it's more than just methods. It's more than just the videos and interviews. It's actually a theoretical standpoint. It's a theoretical standpoint about the knowledge of others, particularly staff and particularly patients, to say that they have very valid and exciting and interesting perspectives on what happens that's very important to put in the room. And it has become a very popular way of doing research studies to look at things like safety and near misses, handovers, what's really going on. Next slide, please. So the theoretical approach in VRE, why use it? Why, what does it add? What does it add to the research? Well, there's 4 principles. The first is complexity. So it understands that healthcare environments, all these environments that we work in, are inherently complex. ASD work, autism work in mental health is very complex. It's not a singular pathway that is very, consistent and standardized. It's complex. Exnovation is the second principle, and that's very much that staff know best. They know what's happening, they know what's going on. We need to be talking and working with staff. Reflexivity I've talked about, and ethnography is this issue of looking at practice as it happens. Next slide, please. So the concept here is work as done, not work as imagined. So not work as people talk about it or say it happens, but work as done. So getting that video camera in and actually looking at what really happens in real life practice. And the ward round for me was a critical site of decision making, a critical site of decisions about discharge, decisions about medicine, decisions about whether or not a patient was allowed to go home or not. And yet very little work done looking at what happens in ward rounds. And the focus is on talk in interaction then, very much talk as it happens, not talk as in isolated sentences for analysis, but talk as it happens. Next slide, please. So I want to look at this opener. This is one turn in talk. The other thing I would ask you as well now, and perhaps you could think about it, come and speak to me afterwards, or you don't have to answer this, but you mentioned that you find PRN really useful and it helps you and things like that. How does it make you feel after you've taken it? What effect does it have on you? Next slide. So why is it useful to do this close analysis of real talk? Is it to see, as Noam Chomsky said, that language in use is messy? No, actually it's the opposite. It's not to see how messy it is, it's to see the very systematic ways that people are using language to achieve certain goals. The doctor here isn't being intentionally misleading, because we all use language according to social conventions. But what my methodology does, what VRE does, is it spotlights the tacit. It spotlights what we're all really doing that we're not consciously aware of. And discourse analysis shines a light on these practices. Next slide, please. So we can all see, because we're speech and language therapists, that this kind of talk is really problematic linguistically. And we know that autistic patients in particular find this complex language very difficult to understand. There's lots of embedded subordinate clauses, there's multiple questions, there's lots of white noise, caveats, hedges. But there's something else. Next slide. It's not also linguistically complex, it's also doing something, it's performing a social action. It's setting up actually a preferred response. What it's doing is it's inviting the patient to think about the positives of taking the medication by framing it in this way. So you mentioned that you find PRN really useful. It helps you and things like that. Next slide. Why is this important? This is important to me because it gets at the heart of patient-centeredness. The doctor on the surface does appear to be involving the patient. So they're using lots of open questions, how questions. And we know that how questions are good, don't we? But actually, when we look at that framing, we can see that that's not good. The patient was actually confused and overwhelmed. The patient is actually being steered towards saying something positive. Next slide. So what the reveals are from this search, let's go to the next slide, sorry, go to the next one. I'm running out of time. Keep going through this, please, Helen, thank you. So what this reveals is that the staff in my research study actually did understand the communication needs of autistic patients. We always say that they don't, but they do. They also understood the nuanced ways autism and mental health interact, and they know how good MDT working is. Next slide, please. But keep going through them. Brilliant. What I found in the video of the ward round is that, in fact, there was almost a total reliance on spoken communication, despite what people know. Very little use of visuals or any other method. The focus was all on mental ill health, not on the autism, and the interplay between autism and mental health is very important. And there was a very dominant role of the psychiatrist. Next slide, please. So what my research reveals actually is that there's something about the way things are done, the institutional practices, that's very much ingrained in the embeddedness of how those organizations work. Go through to the next one, please. I'm going to end on these 3 take-home messages. The first is that standardized communication messages aren't always the best for the patient. So the idea that open questions equals good, closed questions equals bad isn't the story for lots and lots of people, and we need to be more nuanced in how we give our guidance and advice. The second thing is that there's a big overshadowing of mental health in these settings, and still very little kind of practice-based orientation to the autism. And ward rounds are demanding communication environments. There's an over-reliance on spoken word for people who very much have visual preferences. Last slide. Do I have time for the last slide? Yeah, thank you. So Temple Grandin, I want to end on an autistic woman's quote here. She's an animal scientist, she's autistic. She says that she processes the world as pictures. She actually designs what she calls humane slaughterhouses for animals. And what she says is, people want the equipment that I install, to make these slaughterhouses safe environments. But they don't realise that the equipment won't work if the environment is bad. In a plant, the environment means the physical environment, and it also means the way the employee handles the animals. And I think that really says everything about practices, that when we think about the environment, it's not just the walls, it's not just the noise and the lights and all those things that we think about in terms of the environment, it's also the practices, the ways in which we very inadvertently do our work in particular ways that might need changing. Thank you for listening to my talk.
Thank you so much, Alison. That was absolutely fascinating, and I'm really sorry you had to rush there through those slides, because I know there's so much content there, which I'm sure everyone else would agree would have been really valuable to have heard, but it's such a short time, and I did want to make sure we got time for questions. I think reflecting on what you were saying in terms of my own experience, I think there's lots of examples where maybe we institutionalize sort of communication events which aren't necessarily particularly patient friendly. I think back to my role in neuro rehab, for example, and we used to love case conferences, which was our way of involving patients and family in discussions, but really they are, through that lens of patient-centeredness and what you were describing, really not necessarily the most the best way to involve people in conversations.
Yeah, I agree.
Did anyone else have any questions for Alison? Just looking at the chat, it's all gone very quiet. I'm just wondering what's going to happen next with your research. It's obviously on hold at the moment. Have you got any idea about?
Yeah, I'm really fortunate that I had collected half of the data. So, and because of the nature of the data, there's a lot of analysis to do. So I'm focusing on that. I'm focusing on the analysis, and because of the methodology, I can do the analysis kind of midway and kind of do it kind of more iteratively and organically rather than waiting until the end. And also I'm just trying to spend some time writing papers and doing presentations and things like today. So trying to use it usefully. Yeah.
I can deeply empathise with your situation.
Thank you, Kath. I'm putting a very positive spin on it.
You have, yeah.
Yeah.
Sally's asked a really interesting question. How are the staff responding to the videos that you're looking at? Have you had a chance to share anything with them yet?
Yeah, I have, Sally. Thanks for your question. It's a really good question. I think the staff that have got involved have said and have said in interview that they've really enjoyed the process, because what they've said is really interesting things, including the psychiatrists, and they've said that they've seen it like clinical supervision, that they've learned such a lot through the collaborative kind of talk. It's given them an interesting perspective on the patients, because the patients who seem so compliant and so passive in the ward rounds, who then talk quite assertively in the interviews with me about what they didn't like, and then when I feed that back to the staff, they've found that really interesting. I just think there's so much reflection for all of us about not taking for granted people's agreement or disagreement, and kind of they've told me that they've really enjoyed the process.
Yeah, that's fantastic, isn't it, to be so receptive. And again, Christine's commented that she's really interested in your methodology and bringing yourself as a speech and language therapist into your research, which again I think is it definitely resonates really strongly with my own experience. And I think we've got to move on, unfortunately, but what I was going to say was that, you know, what you're doing and by bringing yourself in, really promoting that reflection in clinical practice is kind of what we want as clinical researchers, and why we do these practice-inspired research projects. It's really to learn from what's happening, and feed that back into clinical practice.
I would urge you to look at the video reflexive ethnography stuff. It's the theory behind the staff knowledge is fantastic, and about how much we bring to our jobs is brilliant. It's great for practice-based research.
Fantastic on that brilliant top tip. Thank you so much, Alison. It was brilliant.
Thank you.
Lovely to hear from you.
Thanks.
But last but definitely not least, we've got Sonja Jacobs, who's talking about a co-design project. Again, something which I'm really excited about hearing more about in their community children's therapy team.
Thank you, Kath. Now let's see if I can control it. Now I suspect Helen might need to move it forward for me. Thanks, Helen. So very interesting to hear Alison's talk, because I think there's a lot of things I can, that kind of resonates with me in terms of the complexity of health, and also that staff knows a lot and have got a lot to offer. So we do need to ask them and involve them. So I'm going to talk about an experience-based co-design project that we did in Barts Health in the community children's services. Acute services were actually also part of this, the project. So Helen, if you move on, I'll quickly say, so in the next 12 minutes, very briefly, I'll talk about the kind of design, the methodology, how we did it in practice, and then just a few reflections from myself on what impact it had, and also what I learned from the process as a speech and language therapist, trying to do this in a kind of multidisciplinary format across acute and community services. Next slide, please. So just a little bit of background, a little bit more of the global background. So we're talking here about families, children and families, and children with complex health and medical needs, specifically for this project. And we know that these families really have a tough time. They provide a huge amount of care for their children, more than most parents of children without these difficulties do. And they tend to have lower income, poorer quality of life, their own health problems. So they've got a lot to contend with. And what we know from Tower Hamlets is that Tower Hamlets is one of the fastest growing boroughs in the country. We also have quite a fast growing population of children and young people with disabilities. So, you know, as with many other services, there's no increase in resource, but we need to kind of make do with what we've got and try to make the best of that as possible. So what we decided to do, so the next slide, Helen, please, is we decided to go to the families and to frontline staff and do this project to try and work out, but what are we expecting? What would we like to change? Now, it's interesting because if we look at the next slide, you know, often when in my experience, when we think about changing services, improving services, we tend to go into that kind of top tier of Maslow's hierarchy in thinking about, but is our therapy effective? Are we providing the right input? But actually, with these families with children with complex needs, often it's the things lower down on that hierarchy that prevents them from actually fully engaging with interventions. And I think it was quite interesting going through this project where there was, on the one hand, some fear of from staff and specifically actually from service leads to engage families in making decisions about which way the services will go, what improvements we need to make. And a lot of them anticipated that families will be demanding more. And I think that was their fear, is families will be demanding more therapy, more of us. And it was quite interesting because it was absolutely not what we found. So I think through this process, we managed to kind of look at, but what are the things that we need to scaffold to make sure that we as an NHS, as several services, do not increase the burden of care for these families, because already they have a lot on their plates, and I think sometimes we make their life more difficult rather than easier. Next slide, please. So what we did to do this is we used an experience-based co-design methodology where we kind of, through a process, brought together the views of parents and professionals. So firstly, we started with questionnaires to try and capture as broad a group as possible. So you can move one slide on, Helen. So firstly, with the questionnaires, we got some families to help us to design the questionnaires. So families were involved from the start. So we had a group of parents. They helped us to think about what questions to put on there, what would be useful to know. And then for the staff, we used a standardized questionnaire called the MPOC, or the Measurement of Processes of Care, which is very much around family-centeredness of our services. So on the next slide, you will see just kind of the questionnaire that the parents helped us to design, which was very much, you know, the scaling questions was about family-centeredness and how involved they felt. And then they decided they want those 3 questions, open questions on the first page, which was just kind of just very open questions, which, like I say, was quite scary for the professionals, because parents can say anything. What do you appreciate about the service? What is one thing that you would change about it? And what is the main difficulty you have with accessing the service? So the families said, put those first, because if it's on the second page, the families won't answer. And they were right, because actually most families gave us quite good feedback in the open questions. And we had a response rate of 12%, so we sent it out to 250 families, and we had 30 families return their questionnaire. We actually had quite a bunch back after the project, so the number is quite, I think, a little bit higher than that. And then, like I said, we did the questionnaire with the staff as well. So we got a very broad view of what how family-centered we are and what families would like to see from the service. So on the next slide, so the next bit we did was mapping of 4 children's journeys. So you can move on one slide, Helen. And that is just an example of one little man's journey. So what we did is with the consent of the families, we came together as everyone, or well, as big a group as possible who were involved with little Arthur's care, and looked at all his appointments, who is he seeing, how many appointments has he got. And it was, I think this was quite powerful. It was powerful for parents to see that they're not imagining how busy their life is. And very powerful for the professionals, because for this little man, in his first 3 years of life, he had the equivalent to 86 medical appointments per year, which we counted was 3 every work day. And these are working parents, and you know, they explained how some of these were useful and some of them were not useful. They had to take leave to be able to attend these appointments. They felt that some of them were tick boxes. It was just to keep the professional happy and say, well, I've seen this child, there wasn't a real outcome to the appointment. And it was yeah, I think it was quite interesting to show this to professionals and to see what the burden is that we're placing on families, and not all of this is helpful. So that was a very good exercise to do. So the next thing we did was to go a little bit deeper. So we were using all this information and we were doing some interviews with staff and with parents. And again, some of the information that came from that was quite heartfelt. It was really difficult sometimes to listen to families, you know, a mum talking about her older children, a single mum, and her older daughter was asking her, but why can't she have a disability? Because then she will get some attention too. So it's really sad, but very powerful, because the parents were kind and a lot of them let us video the interviews, which we then showed at the workshops. So that's the next slide, Helen. So we did workshops. Now, you know, it's tricky because we unfortunately didn't get as many parents as we would have liked, but it was rainy days. And families often, there was quite a few who texted me and said they want to come, but they, you know, childcare, or child illness just prevented, or work, they couldn't take additional time off work, so they couldn't participate in the workshops. But that was really useful, and we used all the information from the questionnaires, the mapping, the interviews in these workshops to have even deeper discussions about what we might want to change. So the next slide is just a couple of photos of our workshops that we held at a local special school. And then the next slide is the final one, was where we brought everyone together. So there we had managers who could listen to all these stories. We had parents, we had frontline staff, and all through the process, we kind of narrowed all the messages to try and think about, but what is it that we really want to change? And during that last one, so that's the next slide, we discussed what are the key messages that parents want to and staff, because the frontline staff was quite key in all of this. And it came out that there were some messages around teamwork, and parents were frustrated around the lack of sharing of information between different teams, around not having a key worker. And for some of them, they had, I mean, the average of the 4 children we mapped had 14 medical teams involved. So that was their average, was 14 medical teams. So parents had to kind of try and cope with information from 14 different people. And they also talked about information, the lack of information about services available to them, information about how to contact services, and how they at the end feel like they're just a PA for their child. Support came up as a massive one, where parents felt that they are not getting emotional support. All the parents said that they are very happy, actually, very happy with the therapy services. They felt no one was looking at them and the siblings. So that was a big theme that came out. And then appointments was the other thing. A lot of parents wanted virtual appointments. And now we've got them. So that was a massive theme. So I'll just run through, I know I'm running out of time. So the next slide was just coming back to that hierarchy I think my reflections are that, one, our parents are amazing. The job they do on a daily basis is, I think, you have to be pretty special to be able to manage all of that. I think the importance of family-centered services is really crucial, and to not just see your own little bit at the top of that pyramid. The parents have to deal with a lot. And then also we need to get those basic needs right. It was ICT, information, virtual appointments, information sharing. The basics weren't right. And that's one of the things we need to focus on. Finally, my reflections was powerful. It's powerful to get the real stories from the parents and the staff on video. And that really helps to get managers involved. And I think getting this rich description through this whole process was useful. Things to consider is how to get parents more involved because of the limitations. And I think virtual world will maybe now help in the future. Thinking about, can we involve some of the young people and the children who are maybe able to communicate to get their views? And then also thinking more about the siblings and how we get their views. And I think that's my last slide. So that was very quick, but any questions after that?
Thank you so much, Sonja. That was fantastic and very well kept to time. I didn't even need to whittle my fingers. That was really inspiring. What a massive project. It's fantastic. Can I just ask, first of all, for our participants to share their questions in the chat box, but initially, what are you going to do with that information now? Have you been able to change or streamline any of your services off the back of what the parents are feeding back to you?
Yes, so we've got little working groups now kind of focusing on all the specific aspects. Obviously, the virtual appointments have gone, so we're kind of dealing with that. We are working at the moment on things like improving the internet, the website for information for parents. We're working on a passport, a parent-held passport, where people can share information so that parents don't feel that they have to share all the information themselves. We've got a primary service provider project, which Elena actually spoke about at the last one of these seminars.
Yeah.
Where we're thinking about how do we roll out a key worker type scheme as well. So there's different little bits of projects now coming from this, focused on the kind of identified themes. Fantastic,
that sounds great. Any other questions, pop them in the chat box. I mean, I can keep going for ages. In terms of the co-design, what kind of support did you have to pull some of those concepts together in terms of how you ran those workshops, and what inspired that?
Yes, I was kind of given a bit of a free rein on how I wanted to do it. So, and that was I came across the Point of Care Foundation and their this methodology, and I thought, well, I think that would be the best way of getting staff and parents together and getting management on board as well, and giving that message out. So I had the support of our quality improvement team in the trust as well. So they did a lot of they did all the interviewing, so that it's not a therapist or someone involved in the care. So they did the interviewing for us. They were involved in facilitating the workshops as well, again, so that we were there, but so that it's not skewed by our own views, so that parents can feel that they can talk freely.
Yeah, fantastic. So yeah, some really positive feedback in the chat box coming through. Sally was wondering whether you've been able to share your findings with wider services as well as within your team.
Yes, the project was actually nominated for the Patient Experience Network Awards, so we were a runner-up. So we've presented at the Patient Experience Network, and there's a few roadshows coming up in the next couple of weeks, so I'll be presenting there as well. Again, so we've tried. Obviously, it's for the people who are very interested in this, so we still need to think about how to get it a bit wider. I'm thinking of writing it up as a project, kind of see if we can get it published in a journal or something, just as a case study.
Yeah, lovely, fantastic. I think it's really important to share this sort of practice more widely, because I'm sure that Lee's just said that there's lots of overlap with patients who've got complex neuro needs as well. So I think there's lots of generalization from not just the methodology but also the findings. I think sometimes when we work in silos, even as integrated services, we sometimes forget to see maybe where all those other services are fitting in, and it's easy to forget that people are so you know, their time isn't so in demand in terms
Yeah.
of healthcare appointments, and yeah, there must be a way of streamlining that.
Yeah.
Absolutely fantastic. Right, we're coming to the end of our hour-long session, and again, 3 fantastic presentations with lots of food for thought and some messages that are generalizable across our speech and language therapy sort of patient population. So thank you so much to all our panelists for joining us today. We've got a few more months of presenters set up for to take us through the winter, but if you are a attendee today and you've been inspired and would like to share any of your own practice-based projects, we'd be really keen to hear them, and particularly from we've had lots of marvelously experienced therapists come and share their work, but if we've got any of our newly qualified therapists who've got student projects that they're really proud of and would like to share them, we'd be really delighted to hear from you as well. This is a platform for everyone. So unless anyone has any final thoughts or questions before we get cut off altogether, I just want to thank our presenters once again, and to thank all our participants for joining, and Helen, who's been doing the tech behind the scenes, managing the presentations, and to Katie Chad from the Royal College of Speech Therapists, who's also been supporting. So thank you very much, and we'll hope to see you next month on the 11th. A memorable date, 11th of November. Thank you very much, everyone.